Um, Thanks for the thumbs up there. Good morning or good afternoon if you're here with me in Central Illinois. I'm Krista Rock. I'm the HSHS System Director of Managed Care, and I am so happy to be sharing with you today, although I very much wish I was sharing with you in Las Vegas and not in Springfield, Illinois. But, glad to be a part of the user group this year, regardless of my location. So today I'm going to talk with you about using Parathon for successful payer negotiations. And I'm hoping that everybody learns a little something. So I'm going to start off talking a little bit about Hospital Sisters Health System, the structure and history, just to explain some of our approach for negotiations. And then I'll move on to HSHS and Parathon and our setup for modeling. I'm going to talk about our standard approach to prep work for payer negotiations and our rate structuring, as well as the proposal rate modeling process, some examples of our negotiating reports and modeling tool filters and how we use those to refine our proposals, and then some other considerations in negotiations. While negotiations are about the money, they are also not all about the money. There's a lot more that can be accomplished during negotiations. So about Hospital Sisters Health System, just very briefly, we are a 15 hospital system with 3 physician groups. We provide hospital care in 14 different communities. We do have 2 hospitals in Green Bay, Wisconsin. That's why it's 14 communities, but we are 15 hospitals. There's 9 hospitals in Illinois and 6 hospitals in Wisconsin. Up until 2010, there was no coordinated managed care function for HSHS. I was actually at St. John's Hospital here in Springfield, Illinois, as the director of managed care there. And I was asked to come out here to the system office to start a function for managed care at the system level. So in 2010, I moved out to this office and we did our very first coordinated managed care contract renewal with Blue Cross Blue Shield of Illinois for the, at that time, 8 hospitals here in Illinois. So that's, only 11 years ago were we starting to negotiate contracts as a system. Our East Wisconsin hospitals are coordinating negotiations. Our West Wisconsin hospitals, where we have 2 on the west side, they had started coordinating negotiations, but we really were very separated in terms of the negotiations. There was no one overseeing all of them. So as of now, fast forward 11 years, we are doing all payer negotiations in Illinois as one negotiation. Our Wisconsin hospitals are starting to partner together across the state to negotiate together. And although in Wisconsin, our payers on the east and west side don't have a lot of overlap, but all major payer renewals are also being coordinated now on the same date, because when we came together 10 years ago, 11 years ago, each hospital had negotiated their own contract, which meant they were not only on different terms, reimbursement wise, they were on different contract terms, no same renewal date. So that's been quite a feat just to bring all those negotiations together and coordinated. So a little bit about our managed care team. Here it is quite small. I report to a vice president of managed care, Dan Hooten, and then on the managed care team we have 4 people. We have a division director in Wisconsin, Sherry Tiemann. We have a managed care analyst, Allison Clift. She is on the phone today as part of the user group and is available for questions because she does all of the modeling work. We have a facilitator of managed care, Beth Straub, and then we have a half-time managed care analyst, Chuck Logston, and his full focus is on Parathon. He has been instrumental in bringing all of our databases up and running and keeping them going. And so he is full-time working on Parathon. This team, like I said, we are small but mighty. With our small size, we knew we needed a very valuable tool to do our managed care work. And so when I came to the office in 2010, one of my first jobs was to find a managed care modeling tool, something that we could rely on. And we went through a very large RFP process and chose Parathon and have been working with them ever since. So this powerful tool is very important because this small team takes care of over 600 contractual relationships for our providers. And that is, of course, considering multiple plan types within a particular payer. For instance, Blue Cross of Illinois. We have 9 hospitals. We have 3 rural health clinics. We have 2 physician groups. We have 9 hospitals that might bill professional fees. We have 1 home health agency. Those all require separate contracts for PPO. And the Blue Choice, which is the exchange product, separate contracts for HMO if they're in the HMO, separate contract for the HPN that they are rolling out as a new plan, separate contract for Medicare Advantage, separate contract for MMAI, and separate contract for Medicaid. So with all of these different plan types, with all of our providers, it's an awful lot to keep track of. So in 2011, we began our development of our parallel databases. And we knew when we engaged Parathon that the parallel database was really key in everything else we wanted to do with Parathon. So we developed the parallel databases for all of our hospitals at that time that were on Meditech and Epic. So we've gone through transition of systems, as many hospitals do. And at that time, we brought on all of the Meditech and the Epic hospitals. Today, we have parallel databases live for 13 Epic hospitals. We have 2 other hospitals. I mentioned there were 15. 2 other hospitals that are on CPSI because those are very small hospitals that have joined HSHS in the last few years. So those have not been brought on. Those hospitals are going live on Epic next year. So it is my hope that we can actually bring them in as well. Our process is to do all payer negotiations completed with Parathon modeling. That's incredibly important to us. The payer reporting is also done primarily with Parathon for reporting to our HSHS leadership and especially the payer outcomes reporting. I did mention that we employ 1 Parathon modeling certified analyst, that's Allison, and we do use this modeling feature for all of our negotiations for all of the Epic hospitals. So, preparing for payer negotiations, and we're going to hear a common theme today. Katie said it as she was finalizing her presentation. Data drives change. So right there on top of my slide, data is key. That was one of the points I wanted to make as well. Accuracy and completeness is just an advantage to negotiating with any of these payers. Our parallel databases have all of our UBs and HCFAs. Our provider data through Parathon is better than all of the payers' data. We have seen that time and again through negotiations. The payers often have missing or incomplete data, specifically from self-insured groups. So some of their self-insured payers will do their own claim adjudication. And if the payer that I'm negotiating with isn't adjudicating those claims, they often don't even have access to that data, which is a disadvantage in the negotiations to not have a complete set of data. We have run into some examples of trouble with that, and I'll explain that a little bit later. But we had the advantage because we had all of the data within Parathon. So the current expected payment also being available for all of the comparisons is an advantage, so that we use that in the modeling without, we don't include denial impact or incorrect payments skewing the results. When we are looking at this data and looking at the current data versus what we're negotiating, we're looking at the outcome as if everything's paid correctly. The data set remains unchanged when we're negotiating until we want to refresh it. So that's an advantage over using some other systems. Specifically, I mentioned we're on Epic, probably some of you are too, and Epic doesn't have that capability for us to use a set a model set that doesn't change throughout a negotiation. Sometimes negotiations take months. We've completed one this year that honestly we were working on for 11 months, I think. So it can drag on. So keeping that model set stagnant is very important when you're comparing one set of proposals to the next. When we're preparing for negotiations, we define our data set and we consider a couple of different time frames. So we will often look at the renewal year, depending on when the contract renews, 12 months from that. We will commonly use our fiscal year. We run a July 1 fiscal year. Sometimes we use calendar year, especially if the contract renews on January 1st, but we always confirm what the payer is using, because if we can match the payer data time frame, we generally have better outcomes in terms of getting to agreement faster. Currently, we are also, of course, avoiding 2020. We've been using calendar year 2019 to model most recently, and that's what we're finding the payers are using as well. But we also recognize that some COVID impact is here to stay. It's not going to go away. Some of our volumes are going to change forever. And so we find it important not only to model on the calendar year 19, for instance, but also to model then on a more current time frame of 12 months to make sure that we can see any impact changed volumes have on the rates that we're negotiating. When we're preparing for large payer negotiations, we do auditing through the variance reports to prepare for the modeling. Now, our business office is also using variance reports, but what we have found is we don't always get feedback if something isn't calculating correctly. So we're looking for that to make sure that what we have programmed today is actually calculating correctly, and we look for anything that might need to be tweaked. We're also looking for unknown payer underpayment problems. So something that might be happening, the business office hasn't reported back to us. So we're looking for those too. And generally, our managed care analysts, Chuck and Allison, will look at those and scrutinize those in preparation to get to modeling. So the next step we do in preparing for negotiations is we get some reports completed for our senior leadership. And this is to prepare for setting financial goals. So these are made up rates. I don't know if you can see all of my screen here. I couldn't, for some reason, my slideshow presentation wasn't popping up quite right. But this is one of the baseline reports. These are just example made up numbers. And this is a current payer volume report. It's the very first step, and we pull the overall volume information for the particular payer we're going to negotiate. We figure out what 12-month period is most recent that we want to use. And then we, by hospital, just pull the very basic information: billed charges, number of counts. Our senior leadership always wants to know, how big is this payer? How important is it to each individual hospital? These are the 7 Illinois hospitals I have listed here for HSHS, the expected reimbursement, and then what is the overall payment rate. So the expected reimbursement is based on, again, payment on every claim, as if it had no denials, as if it had no underpayments. It's truly what we expect based on what we negotiate in the contract. So if everything goes right, this is how much we would get paid. The next report that we create this report, although it is based on using Parathon data. This is a percent of Medicare report. This is a report that we use to compare one payer to the next using a general percent of Medicare calculation. So we pull the data, and we also look at, for each hospital, what is the overall Medicare reimbursement rate. It is not, we don't model the payer's claims on Medicare calculations because we don't bill everything in commercial the same as if it were Medicare. So while Parathon has the ability to model on other payers, if we're not billing consistent with Medicare rules, we can't get a true modeling on Medicare for these commercial payers. So we just do a very simple calculation of the overall payment rate for the commercial payer divided by the overall payment rate of Medicare for the specific hospital. That just gives us general comparisons. And so we can compare one payer to the next. We can compare how each compares to Medicare, and it gives us directional information. So while it's not specific, Medicare would actually pay 239.2%. It is for comparative purposes, and we find this really useful when we're talking with our senior leadership about if we are, in this case, negotiating for payer A, and we can provide information on how they compare to payer B, C, and D for our own hospitals, then that helps put everything into perspective when we are determining what our financial goals are. So, for as many years as I've been negotiating, discount for volume has been a driving force in contracting. But one of the things that's resulted in is creating giant payers in some markets, and I'm sure you all have yours. We certainly have our giant payers. And what makes more sense today is tightening up the gaps in reimbursement, bringing those lower payers up to some of those higher payers, because then if the payers are paying your provider more similarly, they have to compete for their membership based on other means, not just based on how big their discounts are. So that's why we produce this. We watch it over time, and we use it to set the financial goals when we are going into negotiations. So philosophies and rate structuring for HSHS, here's a couple of them that we think through as we're preparing for a negotiation. Standardizing methodology across hospitals. So again, I'm going to use Illinois for example. We have 9 hospitals in Illinois. I mentioned that. They were all contracting individually 11, 12 years ago. So we have methodologies all across the board because the individual hospital CFO in most cases was determining what contract they would sign. So now fast forward, as we are working as a system, we are now at a point that we can start standardizing methodologies. So instead of having, DRGs and per diems at 2 hospitals that are, 20 miles apart from each other, we are working to standardize methodologies across the hospital so that they are the same. Now, we don't run a standard CDM. So charges are not consistent from one hospital to the next. So I can't yet put hospitals on the same rates. I can, however, get them transitioned to standard methodology. So if I can get them to methodologies that are consistent, it's easier programming for the systems. It's much easier for the business office because we do have a consolidated business office. So the same person that is reconciling accounts for St. Joseph is reconciling accounts for St. Mary's. So if the methodology is the same, it works better for them. So while Parathon certainly can program non-standard terms, one hospital to the next, they work on whatever we've contracted, it is truly easier for our business office folks to not have to remember that hospital A does it this way, hospital B does it that way. For instance, observation. We had 3 hospitals we were working on recently. One had observation case rate. One had a % of billed up to an observation cap. And the other had an observation case rate, but it was paid in addition to all other rates. So, the same person in the business office that's reconciling this payer's accounts from one hospital to the next has to remember, if she has to look into those accounts, all of these differences. Another one, outpatient surgery, that's a good example too. We have hospitals with groupers, hospitals with % of billed to a cap, hospital with carve-outs, hospitals with implant add-ons, and differing multiple procedure reductions by hospitals. So one of our main goals in more recent contracting is to standardize some of those methodologies so that while the rate itself isn't the same, at least the methodology is. Another philosophy that we stick to when looking at going into a negotiation is maximizing reimbursement on services that a payer won't move to an outside location. So emergency room. Most emergency room visits, if it's an emergency, it's coming to your hospital. It's not going to be driven elsewhere. If it's a true emergency, it won't be driven elsewhere by a payer policy or a benefit design. Observation is another one. Patient truly needs observation care. It's going to be done in the hospital. Inpatient, although you have to watch for inpatient procedures moving to an outpatient. That, of course, is happening over time as well. Other thing to consider is commodity services and pricing them at a more competitive reimbursement level, like lab, radiology, especially MRI, CT, sleep studies, and therapies is another good one. Those are services that can be provided at lots of locations. It does not have to be in a hospital. Freestanding locations are numerous in some markets, not as much in our rural markets, but they are becoming more so. So updating all these rate structures and considering all of these things is harder than simply negotiating a % increase with the payer, but doing all this hard work leads to efficiencies in the business office. It leads to better outcomes over the long term for your rates, and it's truly just worth the effort. So when we are preparing the initial proposal, this is the most time-consuming part of the model creation. But first, we work with the payer to determine first their appetite for structure change. I will call my contract negotiator. Most of them I've known for a long time and I've done a lot of work with. They've been very receptive when we've been doing these big rate structure changes. They've been very receptive, especially having that conversation up front. What is their appetite for structural change? Also, in terms of some of the rates, I ask them what is their preference. And in some rates, their preference will match ours. I have to see, does their preference match ours or not? And if it does or doesn't, does it actually matter? For instance, I'm working with a payer that we have 2 contracts, newborn codes for inpatient. One of them is pricing off of revenue codes. That's how it's contracted. Another is pricing off of DRG. They're both per diems, by the way, but one uses revenue code, one uses DRG. And so I asked, do you have a preference? Because honestly, I can make it work either way. I will set the rate appropriately. I just need to know which one in this case is the payer's preference, because I can do it either way. Payer policies, that's also important. How does a payer apply certain policies? For instance, clinic revenue codes, revenue code 510. We have contracts that have rates in it for revenue code 510. We have contracts where we are getting paid 0 for 510. I have 2 hospitals within 40 miles of each other. One of them gets paid for their clinic codes 510, the other doesn't, from the same payer. Does that make any sense whatsoever? No. So these are some of the things that I'm trying to manipulate during negotiations for more standard approach to how claims are actually paid. So changes to structures, we're consolidating the structures, and we have to decide within our system where to consolidate methodologies. So it starts with looking at where the hospitals, what their rates look like today, how different are they from the next, and really with 9 hospitals, it just takes some logic. Depending on how many hospitals you might have in a system, it just takes some logic and thinking, does it make sense? That's usually the first question. Changes to inpatient or outpatient structure. We have old contracts on per diems for some hospital. Really, we're moving to the DRG methodology. It just makes more sense. It makes more sense for case management and for the business office. And then adding and changing fee schedules. One thing that we're looking at closely is adding or changing fee schedules specifically for shoppable service. Like some of those services I mentioned that are commodities, lab, RAB, definitely good examples. Again, we can add those fee schedules at a more competitive price so that the patient has choices on where they want to go without spending more for, say, at the hospital. And by adding those fee schedules, we can just restructure where that reimbursement goes. The other thing that we do is look for terms that are problematic for correct payments. And underpayment variance reporting is invaluable for this. That's the first look at where is the payer consistently paying us wrong. The other thing is finding out what a payer has in the contract that they have to manually adjudicate. Change that. If they have to manually adjudicate a term in the contract, that's not a term that we want in a contract. We were negotiating with a large payer in the last year, and something we had agreed to, the payer, we actually had a change in negotiators. And the new negotiator came in and she said, okay, I see that, this is what we're agreeing to here. They'll have to manually adjudicate those. I said, whoa, that was not our intention. So once we understood that their system could not program what it was we thought we were agreeing to, we changed directions on that. Parathon can create payment methodologies. And this particular term that we were working with, it was already created in Parathon. It was in our modeling tool, but the payers can't create methodologies nearly as easy as Parathon can. So we try to avoid anything that the payer says has to be manually adjudicated. It just doesn't normally end well. So when we are doing a proposal, part of the greatness of the Parathon modeling is the specificity that we can get in the modeling itself. So when I talk about modeling, I just want to make sure it's clear. Allison does all of the modeling. She is certified to do modeling in Parathon. So much of what I'm going to relay here is actually work that Allison does. She's on the phone to stop me if I get anything wrong or to answer any questions that you might have. But some of the things that we very much use with the specificity of modeling in Parathon is the rolling of claim dates. So if we're using a calendar year 19 model set, Allison will roll it to whatever year we're going to negotiate for. So she can roll those claim dates. It will apply the increase in CDM. It will apply more current rate schedules, DRG weights. If we're working with governmental payers, it'll apply the current rates to those older claims. So that's really valuable to get that old claim set that we're using modeled on current rates. So that is what we use then for our comparison to whatever we're putting together for the proposal. It also allows us to apply updated DRGs or DRG weights, CPT codes. There's a feature that we've used that allows you to update coding in your model set. And this is when codes are on claims, but those codes are no longer used. So CPT codes that have been updated, for instance. It's really important for major code updates if there's a lot of volume. A few years ago, we had an example where a whole bunch of mammogram codes got updated. And so a special conversion table was built in the model set, and it was like a crosswalk. So it's a crosswalk from old code to new code, but it does it then within the model set so that you can you don't have zero show up on those claims because the code's no longer valid. You don't get a wrong rate on those claims. You actually can model those claims with the new codes because it has crosswalked those codes. So I'm going to show you a snapshot of some output of the negotiation reports. Again, this is all just completely made up data. But this is one of the standard reports. This is a service line report. And I hid most of the MDCs on inpatient because I wanted outpatient to all of the lines to show on this slide. So this is the standard report of output. It's very quickly and easily produced. It shows by MDC here in inpatient, and then outpatient, you have your ambulatory surgery groupers, you have cardiac cath, ED, miscellaneous surgical, revenue group per service line, and urgent care. It shows across the top here the billed charges, expected reimbursement, and the current base liquidity, which is important. Then in your first proposal, which is Model 1, it shows the billed charges, expected reimbursement, liquidity, and then the model difference. And this is the billed charge change. So remember I said that if when the claims rolled forward, it'll increase the charges if you had a CDM increase, and the expected change. So those are the important ones here in yellow. Base liquidity, then your first model set, and what is the actual change in that first model set. So when I'm looking at these reports, we're looking for several things. First of all, these yellow boxes that I've highlighted here are the first things we look at because, of course, we set a financial goal. We set a financial goal when we started these negotiations. And so we're looking for total outcome. But then within the inpatient line, we're going to look at that increase as well as the overall outpatient increase. We're also going to look at these service line increases, or in this case, decrease. You can see the revenue group per service line has a significant decrease on this line. That is where lab and radiology and other things will fall into this bucket. So it's a pretty large group. In this case, I would think we were adding or changing a fee schedule that was a significant decrease in this revenue group per service line, which would be intentional. That would be an intentional shift here, but it gives me the data I need to see how did that fee schedule, what did the decrease amount to? How did it affect the overall outcome? And do I need to inflate or deflate that fee schedule? So this report gives me the service line level information. If I have this Model 1 and say it's way low, maybe I was intending to get it to 16% increase, then I can target specific areas based on the outcome here for Allison to remodel with another proposal to increase the areas that maybe I think need to be bumped up a little bit more. So this is the very first model that we use on a first proposal. This report also will hold up to 6 different models. So across the top, you will see Model 1 here, but then you would see Model 2 up to Model 6, depending on how many iterations you do, which is really nice because then you can keep your counter proposals that you get from the payer in the same model set and look at them side by side. One of the other things I do with this report, sometimes more often than others, this is the same report, but using a different filter. It's by payer within a payer. So you can see this is actually Aetna. These are the plan codes for Aetna. This particular snapshot, there is a Model 2 on it. So you can see the side-by-side Model 1, Model 2. This is really useful, for instance, when you have a payer that has one of the TPAs that they don't have access to the data. We ran into this when we were negotiating with Aetna, which is why I included this particular page, again, with made up numbers. Meritain is a TPA that uses the Aetna contract, but Meritain adjudicates their own claims. Aetna does not have access to Meritain data. So generally speaking, this isn't a big problem. However, with Aetna, it was a very big problem at one of our hospitals. Meritain data accounted for, I think, 48% of the Aetna total business at one of our hospitals. So Aetna was modeling rates, and they had a different outcome than what we had. And we were able to narrow it down to Meritain data being 48% of the total. And the services that Meritain was using were actually lower reimbursed than the services that the rest of the Aetna book of business were using. So it was when Aetna would model without the Meritain data, they were getting a higher percentage than what we were modeling when we used all of the data. So we used this report, and then on the second tab of this report is a claim level report with tons of information. So we used the claim level report then to narrow it down to the Meritain business and look for areas that were driving the total for Meritain. Because honestly, Aetna came to me and said, we have to meet budget based on the Aetna business alone. Can you shift anything so that you're shifting reimbursement to Meritain away from other Aetna so that Aetna could get to their total on their own modeling? So we used the claim level report on the second tab of this report to find areas that Meritain had higher utilization. It was really interesting, actually. They had much higher utilization in stop loss claims. And so we were able to adjust the stop loss provision to accommodate part of Aetna's need to have their modeling look lower. So again, our data is using Parathon better than the Payor's data. And we were able to get to a result using this and finding those areas that we could manipulate. We were able to get to agreement with Aetna because we could get to the data and manipulate it. So other negotiating reports, and I mentioned some of this just a little bit, there's claim line detail reports as well as claim level detail reports, which I just mentioned, to find where specific rates are hitting. On the claim line detail, we use that when we're investigating service areas in some kind of outcome. If we're trying to get to a new total and we need to manipulate certain areas, we don't just have to inflate everything. We can really get to many different areas to make sure that our reimbursement increase or decrease makes sense and is the best that we can do for our business. So then I'm going to show you in the modeling tool, there are modeling filter screens. Allison uses this when she's reviewing the modeling for expected reimbursement calculations. It allows you to target very specific service categories in the fee matrix for reviewing the accuracy of the modeling or for getting reports of claims in specific service categories to create a narrower sub-report for analysis, which we ask her to do sometimes, and for targeting claims that might need to be repriced based on a correction. It's an extra modeling tool that Allison uses quite a lot. And I'm going to go a little closer on those red boxes because these are the filters that are used most often. So the first three are pretty self-explanatory, ER or non-ER, outpatient or inpatient, medical or surgical, pretty standard. The next red box gets much more specific. So the service revenue grouping and service procedure grouping. Revenue grouping narrows the claim to revenue codes billed, and service procedure grouping narrows to specific procedure groups, which is helpful as we've negotiated outpatient surgical grouper rates. A procedure group is created for each of the surgery groupers. So when Allison is checking grouper pricing, she can use this filter to find claims that are in a particular bucket. Sometimes when we're narrowing in on those outpatient rates, we will look at those individual grouper rates and grouper buckets to see what's hitting there maybe to adjust up or down in particular targeted areas. The third red box is another way to find very specific pricing for review. Service CT is a calculation type, and Service CM is a calculation method. And both of these show how the claim or the claim line should price in the fee matrix. So if we are trying to, again, hone in on an area for investigation for one reason or another, or to inflate or deflate, this is another way to find what is hitting a certain type of fee within our proposal. And when we're modifying the rate proposals, that's what we use to look how to maximize or how to balance reimbursement. We use very targeted approach to our rate proposals instead of just guessing, or instead of just inflating everything and seeing how the payer reacts. So other considerations during negotiations, because of course the money is key, but we're looking at other things too, and denials is the first one on the list. Katie showed a scorecard, and using some of the denial tools that we have, we do look at that. Although the denials are not tied to the claims that we use in modeling, so they're not accounted for in the financial piece of modeling, we use that just in terms of our discussions overall. If we need to take into consideration a particular payer's rate of denial, that's more of a discussion we have that we don't specifically generally tie to the rate proposal. Most payers have not had to go to the length of tying denials to our proposals. We did have one payer we were negotiating with that we were having trouble getting to agreement on how what the proposal outcome really was. And so we did have to get down to a list of claims that they had denied that we included in our data set. So, but that's more of a rarity. We're usually reviewing denials for an administrative discussion, not necessarily for the rates themselves. Underpayments, individual payers not paying according to contract. Okay, so underpayments, there are underpayments of all types. We have recently had two major payers that we identified underpayments, and we took them to the representative of the payer, and they investigated and came back and said, oh yeah, that plan doesn't have to pay according to contract. We said, well, what do you mean that plan doesn't have to pay according to contract? And one of them is a federal plan of some kind, and I don't know what the other one is, but the payer is now telling us that their plan doesn't have to pay according to contract. So, you know, that leads us to the logical decision that why are we contracting if plans can just choose not to pay according to the contract? So those situations are sitting in our legal department now. Not sure what the outcome of that will be, but that is something to consideration. Underpayments for all reasons should of course be considered during negotiations. Transparency data, of course, is available now at varying degrees. Some of it's easier to read than others, but certainly we are looking at transparency data from our competitors to determine the level of payment to those competitor providers, because that's just another tool we now have in our toolbox in trying to negotiate our contracts. Hospital pro fees, we do consider hospital pro fees during negotiation. Our hospitals don't bill a lot of pro fees though. So it's not a major consideration when we are negotiating with payers, but that data is available in our parallel database. Allison does run that data so that we have an idea right up front of how big that bucket of claims is. Generally for us, it's not that big. And another thing that we do consider now is payer policies. And so the payer policy impact, and I know Pat mentioned this earlier today, payer policy impact, we're seeing more and more of these payer policies coming out. The goal obviously is just for the insurance company to pay the providers less. That really is the goal, no matter what they call their policy, that's what they're looking to do. And we're seeing lab volumes affected, radiology volumes, specifically sending MRIs to freestanding locations. Site of service policies, colonoscopy has been around for a little while now. We've seen site of service policies on outpatient surgery centers, and this was a kind of a funny one. We had a Medicaid plan in Illinois come out with a site of service policy for outpatient surgery centers. And we said, okay, well, that doesn't apply to us because there are no outpatient surgery centers in our markets in central Illinois. And they came back and said, oh, no, there is one here in Decatur. In Decatur, in very central Illinois, and it was, within 60 miles from one of our other hospitals. It was actually 59 miles, so they said it was within range. What we had to tell them is that we actually owned that building and had closed that surgery center a couple of years ago. So site of service policies for outpatient surgery aren't very active in our markets yet because we don't have alternate surgery centers, but the payers certainly are trying to do that. So we consider all of these payer policies when we're looking at our rate structures and developing those rate proposals. And we're looking at what could be shifted to a freestanding location, what could be shifted outside of the hospital. Lab and radiology, certainly we've seen some of that already. We will likely continue to see more, but we definitely use the data that we have in Parathon to assess what is our volume now, what will that mean if it shifts, and how do we structure our rate proposal to accommodate potential loss of those service lines. So that can help us quite a bit in reporting to our senior leadership and with negotiating with a particular payer. And in some cases, we have been able to negotiate rates for services that might move outside of the hospital. If we negotiate agreeable rates, we can be excluded from the particular policy. And that's generally what our goal is, because our patients in most of our rural markets don't really have good options to go elsewhere anyway. So to sum it up, we rely on modeling and Parathon for all of our payer negotiations. We are confident in what we negotiate and how we can predict the outcomes by using Parathon. And it really allows us to get to a level of specificity that we feel good about going into those negotiations and then into that contract term. So thank you. And if anybody has any questions, I would be glad to take them.